इधर आ जाओ भाई, इधर इधर स्टैंड दिस साइड, यहाँ पे लाइव चल।
Good morning, everybody. So today we have a topic of medical legal discussions in cases of obs and gynae. So for that thing, let us take 3 cases, clinical based scenarios से भी, and then let us decide इसमें क्या medical legal है क्या नहीं है. Whether you can come up with आपको कुछ लगता है कि इसमें problem or this can be challenged in the court and something like that. So we have 3 cases. Half an hour है हमारे पास. We will take 3 cases, 10 minutes each. Can one of you take up the time, please? 10 minutes. Okay. So we will start the first case. We will have 3 cases, 2 from obs and 1 from gynae. Obs, maybe final years may be knowing, but then for the first year and the second years, obstetrics is something which deals with child and childbirth. It is a medicine which deals with childbirth. So we have 2 lives. One is the mother and the other one is the fetus, which we are supposed to look after. So that is why we will take 2 obs cases and 1 gynae case. Obstetrics is actually difficult. Why? Because we are dealing with the mother and the fetus. But mind you, it is not only the mother and the fetus, it is the entire family. Daad ke, naan ke, everybody comes together when it comes to childbirth. So we will have 2 cases, one in the early pregnancy and one in the late pregnancy. So first case is that patient comes to you on such and such date. She says, I have missed my periods and I am 2 months pregnant. But the problem is she doesn't want to continue the pregnancy. The husband says, no, we have hardly, after a very long time we have conceived and so we want to continue the pregnancy. Okay, you get an ultrasound done. I will tell you the management also in continuation, however we manage the patient, and then we can discuss about the medical legal aspects. Okay. So we got an ultrasound done, we confirmed the viability. The ultrasound says it is a single live intrauterine fetus of 8 weeks period of gestation. Cardiac activity is present and it is a very well healthy pregnancy without any complications. Okay, so then you put in folic acid and send off the patient. After 1 week, the patient comes back again. Madam, I don't want to continue the pregnancy. I told you earlier also. I am telling you again, I have certain issues with the career and everything. My promotion will be lost. And so I am supposed to destroy this pregnancy. I don't want to continue it whatsoever. So now how do you proceed? The whole family, including the husband, one side, only the patient says, I don't want to continue the pregnancy. So as a doctor, just because the patient is saying कि मुझे pregnancy continue नहीं करनी, you are supposed to go by the will of the patient and you prescribe an MTB kit, medical termination of pregnancy kit, and we can very well manage it medically without any surgical intervention required. After 1 week, she comes back, you tell them कैसे लेना है, कैसे नहीं लेना है, and after 1 week, the patient comes back again, you get an ultrasound done, all is fine. So do you feel any medical legal problems in such a case? Anyone? But you have to be interactive, है ना? Medical legal thing is nothing which can be put in a syrup and they can be given it to you. You have to think. You have to think, you have to be joining with the patient, you have to interact with the patient, and then you have to come out कि क्या problem आपके ऊपर आ सकती है. Perhaps हमारा time तो निकल गया. When you people will be practicing, you will have more of medical legal issues. So you need to be very careful. Do you think what we did was right? Anyone? Okay, so how many of you say yes? पीछे वाले sleeping, जहां पना, you और जहां पना ना, sleeping. So do you feel what we did was right? Any changes of opinion? Anybody who has to give a different opinion? Nobody from the husband side. Very good. Somebody is standing from the husband side as well.
The treating doctor should have taken the consent of the female as well as her husband because he is the legible father of the child. So the consent of husband with his due signatures and the consent of the female should have also been taken.
Okay, very good. Anybody else? Okay, second issue in this. Perhaps after 1 week, we will come back to it again. After 1 week, the patient comes to you and you get an ultrasound done and you find a little bit of retained products still there inside the uterus. And now you counsel the patient and you have to take her up for a suction evacuation. You need to take the patient to the OT, get a PhD done, a surgical evacuation bhi karna padega. And then the patient will be fine. So now, what is the difference between case 1 scenario and the case 2 scenario? Now the husband says, अब मैं नहीं consent देता, अब कर लो जो करना है, मैंने तो मना किया था पहले भी. Now what do? Again you are in a problem. So now what will be the medical legal problem you face here now? Anyone? Okay, so let me tell you, for an MTP, for a tubectomy, for any such procedure, only maternal request is more than enough legally. Yes, as far as we are in India, we do involve the whole family, no doubt about it. Of course, the family matters. But as far as law is concerned, only female's consent is more than enough. The husband says, "मेरी permission मिली कोई बात." We are not at fault, right? As a medical person, you are not at fault. As a healthcare provider, you did what the patient wanted to do. But yes, the problem was at the first onset itself, you should have told the patient there are chances of retained plus you are already 9 weeks. The MTP kit works effectively till 7 weeks period of gestation. Uske baad, there are chances that you may land up in RPOC and we may have to take you up for a suction evacuation procedure later. Okay? In case they would have given their consent then and there itself, you were absolutely okay to go ahead with the procedure. Right? 10 minutes over? Right? That's good. Okay, we will go to the second case. Recently we had a case. 20. Sir?
Similar case है एक बार कोर्ट में भी हुआ था ऐसी लेडी went for abortion without the consent of the husband but husband filed a case against the doctor again कि आपने abortion क्यों किया the doctor said कि as per law as per MTP Act only female consent is required okay and this MTP was as per clauses falling under MTP Act so this was not out of MTP Act so doctor अपनी तरफ से ठीक था but husband filed the case ठीक है तो कोर्ट ने ये कहा कि देखो आप डॉक्टर के अगेंस्ट केस नहीं कर सकते आप अपनी वाइफ के अगेंस्ट केस कर सकते हो बिकॉज इट्स अ क्रुएल्टी टू यू आल्सो बिकॉज शी अबॉर्टेड विदाउट योर कंसेंट इट्स अ क्रुएल्टी ऑन हर पार्ट आल्सो बट नथिंग बी अगेंस्ट द डॉक्टर
So the doctor is safe.
But preferably doctor should
yes.
कुछ लॉ के कुछ हमें सोशली भी देखना चाहिए डॉक्टर शुड प्रेफरेबली टेक द कंसेंट ऑफ द husband also in such cases
Exactly.
Go separate ways that they will lead to divorce.
Right, that is what I said. That is what I said. As far as you are in India, we always take a collective consent. है ना पूरी family को बुला के counsel किया जाता है. What is the present condition? What will happen? What we can do later on? What can be the future chances? Everything. But still, medical legally, as a doctor, you are not wrong. Okay, you have to be safe on your part. So we'll take a second case. A 20-year-old female has come to the emergency. She was a booked patient for you. I mean, booked patient in the sense she has been regularly showing to you in her antenatal period. She was a breech presentation. You had already told the patient that she is a breech, she's carrying a breech fetus. and that she should come in emergency as soon as labor starts, or in case whatever, if anything goes wrong, she has to come to the emergency in any way. But then after 1 week, the patient comes to you in the emergency, bleeding badly per vagina, and she has got a uterine pack inside. She went to some other center, where she has put in they have put in a uterine pack because she was bleeding very badly. She has undergone a cesarean section last night for bleach presentations. And after that, now they have referred the patient to you in shock. Patient's pulse is 130 per minute, very steady. The BP is not recordable on the monitor. If you take a manual BP, it is something around 60/40. You rush fluids and you rush the patient to OT. She's bleeding per vagina. There is a pack inside. You need to remove the pack and see what is bleeding. Where is the bleeding coming from? So we take the patient to the OT. Jaldi shift karke and intubated the patient and shifted to the OT. And we find that locally when you examine the patient, everything is okay. You're able to see the cervix, all well, no active bleeding from inside. In the meantime, in the OT, you get the reports saying, lab say, HB is 3 gram%. The TLC count is 26,000 and the platelets are 50,000 only. Now what? Then you take God's name and then you try to remove the pack because you want to see where is the bleeding coming from and you want to control the bleeding. Anyhow, the pack was removed very nicely. The patient did not bleed at all. So she was given neutrotonics. Perhaps it was a case of atonic PPH for the final years. Perhaps it was a case of atonic PPH. So you increase the neutrotonics dose. You control the tone of the uterus. Patient stops bleeding. You are okay. But the anesthesia people say we will not extubate the patient because she is in shock still. The patient was started on norepinephrine at the rate of 10 ml per hour. And then slowly it was decreased as the BP started coming up. At the same moment, you transfused 2, 3, 4 units of blood so that the patient doesn't go into hypovolemic shock. Right? This was the management done. At 12 o'clock, the patient was fine, shifted to the ICU, taken care of as per the charge, jo monitor karna hota hai. Good morning, I'll be asking questions. अपने पीछे वाले बच्चों को बोलो. I'll be asking questions. तुम्हें. Okay. At 3 o'clock, the patient again had a very heavy episode of bleeding per vagina. In the ICU, it was seen the bed was full of blood and the patient had to be shifted again to the OT. Per abdomen dekha, the uterus was again flappy, it was not contracting and she was pouring as if you have opened a tap. So patient's relatives were come. Dekho bachcho, patient is intubated. Patient is not in a condition to give a consent for anything. She came to us in shock. So whatever it is, you explain to the patient, this is the present condition, and perhaps we will have to open up the patient, take her up for laparotomy. If the uterotonics don't work, we will have to close the uterus with the help of some sutures. The final years may know how can we control PPH. But if that doesn't work, we may have to remove the uterus in the same sitting. Mind you, she is only a 20-year-old female. Okay, so on table, opening up the patient, and then you see you give carbinosin, oxytocin, everything given, but the uterus doesn't contract. And slowly you see on the left side of the uterus, there is a huge hematoma. It is increasing in size. So on table, we call the senior surgeons, the senior faculty, everybody comes on the table and collectively a decision of obstetric hysterectomy is taken. Obstetric hysterectomy means the patient has just delivered and you're removing the uterus. That is obstetric hysterectomy. So we do an obstetric hysterectomy. She stops bleeding, her vitals start improving, and then she is shifted to the ICU later on. 2 days later, the patient is extubated. She's maintaining her vitals, and now she is fine. So let us discuss the medico-legal aspects of this patient. Anyone? Can they tell me what all can be the problems faced by a doctor? कि आपने ये कर दिया, आपने ये कर दिया, आपने ये कर दिया. Anyone? Final years? बोलो बेटा. Hysterectomy was performed. That can lead to? Yes. Patient's hysterectomy has been done without her consent. Anything else? Anybody else? No other problems? Anybody else would like to comment? No other problems, only this hysterectomy? Okay, let us discuss. First thing the patients or the relatives can allege you is, जब आपको पता था इतनी bleeding हो रही है, तो पहली ही बार में hysterectomy क्यों नहीं करी? This is one way of putting it forward. है ना? We took the patient twice into the OT. In fact, this was the fourth time the patient had gone into the OT. Because पहले उसका एक cesarean हुआ था, one OT. Then after that she bled badly. She went to another center. वहाँ पे uterine packing was done in the OT. Third time we explored her vaginally. And fourth time the patient again went into the OT within 24 hours and an obstetric hysterectomy was done. So the patient can allege, and the relatives can allege you, जब पता था कि she is bleeding so badly, she is in shock, she is about to die, why did you not remove the uterus at the first sitting itself? That is one thing. So any answers somebody can give for and against the problem? Final years?
From graduate the following lines that is going to be respectively the first setting. And according to the doctor, the decision was not required by exploring in the first setting. Is it required or not?
So how did we come to know that it was not required?
Because it didn't bleed.
Wonderful. So the point to save yourself and standing for the motion, we did not do a hysterectomy in the first sitting itself is one thing, because the patient was in shock, perhaps she would not have withstood such a detrimental procedure. One thing. Second thing, when you explored her, she was not bleeding actively. If she is not bleeding actively, uterus can be managed with the help of a uterotonics. And while giving uterotonics, she had stopped bleeding. Why do you want to take up such a radical procedure for a 20-year-old female who still has her life to go through? Right? So in that case, you can be safe in the first method. The second problem is, फिर आपको इतनी देर बाद पता चला, and then again after 4 hours she bleeds badly, almost half of her blood is out, and then you do a hysterectomy for her. So you can always say that this was a life-saving procedure for her. Had we not removed the uterus, she could have bled to death. That is why it was an emergency procedure. Patient was already intubated. She was in shock. We could not take the permission of the patient. And in such a case, the permission or the consent from the relatives, from the near relatives, from the husband is okay enough by laws. Sir will tell you better. By law. That consent has to be taken. You have to take out 2 minutes to explain everything to the patient's relatives, put it in writing, what all has happened. Your records, your documentation in the file should be appropriate and clear, and then take up the patient for such a radical procedure. You know, Bachchan, the patient is already intubated, and you are putting a very morbid condition over her. She may survive, she may not survive. This thing should also be written in the consent. She may survive the procedure, she may not survive the procedure. But what you are doing is actually for the good of the patient. So that is why such kind of permission, even if the patient's permission is not there, it can be done. It is okay. Any other problems you face with such a patient?
One is that in these cases, whenever patient post-delivery comes and the patient is in shock, the number one and the most important possibility is the bleeding. maybe internal, maybe external. And if there is no external bleeding, we must have the possibility of internal bleeding. Recently, there was a possibility of some other thing, but the most important possibility is the internal bleeding, and everything should be done as fast as possible. As fast as possible. Second is this about the NORAD. So we should not go that preferably with NORAD. It should be more of the this blood replacement. That is the first treatment. If sometimes we start with the NORAD, we rely on NORAD, that is not the good thing. Because NORAD will lead to alpha vasoconstriction. Alpha vasoconstriction is already at the maximum. The patient is cold, clammy, all the peripheral vessels are already alpha constricted. So we should go more with the blood transfusion, and we should very actively go for the laparoscopy for looking for the internal bleeding if there is no external bleeding.
So for this patient also, we got an ultrasound done saying that everything inside was okay. So that is why we managed it like that. Any other issues you would like to talk about? We stay in a social country like India. No one? Anyone can come up with some other social problems later on in life? Please wait a repeat.
Ma'am, it will lead to the complete destruction of the reputation of doctor, and all the blame will be on the doctor that their treatment was not proper and all the problems were there.
Like when the patient is safe.
But still, ma'am, I believe that the Indian society is of a kind that they just blame the doctor.
That's right. What else we could do to save the life of the patient?
As we are from this field, we understand that the doctor did everything they could, but I don't think the normal people understand it that much sometimes.
This aspect is right. Perhaps you're not able to put it further in a better way. It is like the baby is alive. That's what that baby is still alive. Male child. Done, ma'am, done. Yes, we stay in a country like India. Had it been a female child? Exactly. The third point was she was 20 years old when she delivered the child. A teenage pregnancy is per se a high risk pregnancy. They are bound to fall into complications. They are bound to land up into problems. But then our society still doesn't understand. She was married 2 years back. That is what the family told us. Of course, she was married 3 years back because the sister-in-law told us. She was married at the age of 16. Okay, they did not take her away for the in-laws' house. They took her away at the age of 18. And after that, the husband had some visa, Dubai, he went off to 1 year again passed, and then she got pregnant and she delivered at 20 years of age. The other problem is, now that she doesn't have a uterus, perhaps she may land up into menopausal symptoms very early. I don't know first year, second year को कुछ menopause के बारे में पता है कि नहीं, but there are severe temper tantrums, which so they are definitely preserved, but then there is something known as a post-hysterectomy ovarian trauma, and if she goes into menopausal symptoms not at least at the age of 60, she may land up at the age of 30. शायद अगर immediate ना हो तो at least at the age of 30, 35 she may land up with menopausal symptoms that may hamper the quality of life later on. And you need to help her for that. Now she will be a chronic patient for you all throughout her life. Okay? Time. Okay. Okay. Then we will take the third case, a gynae case now. Sir.
मैं रियलाइज ये करता हूँ गाइनिक जो है ना बहुत ही इमरजेंसी ब्रांच है, तो जो भी स्टूडेंट होम्स के प्लान करते हैं ना, प्लीज उनका ये एटीट्यूड होना चाहिए, बिकॉज लाइफ सेविंग है, और लाइफ सेविंग भी बड़ी यंग एज की आप लाइफ सेविंग करते हो, ठीक है। क्योंकि मेरा भी एक्सपीरियंस है, मतलब वंस आई वाज कमिंग पर ट्रेन नाइट में मैं ट्रेन में आ रहा था और रात को अराउंड 11:30 या 11:45 पे मेरे को एक कॉल आई कि जी एक पेशेंट है, पेशेंट वाज नोन टू मी कि उनका एक्टोपिक रप्चर हो गया, एक्टोपिक प्रेगनेंसी रप्चर, एंड तो मैंने जैसे बताया कि उसका टैकीकार्डिया भी हो गया, उसका बीपी फॉल कर रहा है कि पेशेंट इतनी शॉक, हीमोपेरिटोनियम मतलब एब्डोमेन में ब्लीडिंग हो चुकी है, ये इमरजेंसी है। ठीक है, मुझे याद है मैं ट्रेन में बैठा हुआ था, ट्रेन में मैंने डॉक्टर मिनी मैम को फोन किया कि मैम ऐसे ऐसे केस है, मैम कहते हैं आई एम कमिंग, सिट्स 11:45 नाइट और मैम नॉट स्टेज इन द कैंपस, कहते हैं आई एम कमिंग बिकॉज शी इमीडिएटली रियलाइज द इमरजेंसी की इट्स एन इमरजेंसी एंड फीमेल एज वाज जस्ट 25 ईयर ओल्ड। ठीक है, इमीडिएटली शी सेड कि डॉक्टर साहब आप उनको पहुंचाओ, बस इमरजेंसी में पहुंचाओ, आई एम कमिंग। शी केम और ब्लड अरेंज किया, फाइनली दैट पेशेंट सेव्ड, इसका लेप्रोटमी हुआ इमरजेंसी, 16 यूनिट्स ऑफ ब्लड वाज गिवन। ठीक है, 16 यूनिट ऑफ ब्लड वाज गिवन और पेशेंट को पता ही नहीं है कि मेरे को ये प्रॉब्लम हो सकती है। ठीक है, पेशेंट को द रूटीन मतलब जस्ट इट वाज रूटीन प्रेगनेंसी एंड शी जस्ट हैड रप्चर्ड प्रेगनेंसी, उनको एक्टोपिक का भी नहीं पता था। तो जस्ट ओब्स गाइनी ना बहुत ही इमरजेंसी ब्रांच है और इसमें आप किसी की जान बचा सकते हो और वो भी एक यंग एज की जान बचा सकते हो, बट यू हैव टू बी वेरी क्विक। अगर मैम कहते कि नहीं तो रात 11:45 हो गया, हम कैसे आऊंगी, हम कैसे करेंगे, ब्लड बैंक वाले कह देंगे हम कैसे अरेंज करेंगे, क्वेश्चन इज कौन। ठीक है,
About this consumer court cases, in our country it is not at present. In the US, what is the situation at present? There, every doctor has to preserve the record of that obstetrical delivery for at least 18 years. Because when the child gets 18 years, he can see the patient, the doctor at that time. That why you did it, this thing, you didn't do this thing, I was having some mental effect because of that. They have to preserve the record for more than 18 years till the time the child is able to sue the doctor. It is a very critical situation for the doctors at that place.
So this even happened in Kerala, and the baby came out to be mentally challenged approximately at the age of 18 to 20 years. And after that, the parents sued the hospital कि शायद delivery के time पे कोई problem हुई थी, which you did not share with us. And so now our child is not able to crack the NEET entrance exam. That was one case. And that's true. Jubilee Mission Hospital के ऊपर case हुआ था, इसीलिए. And so after that, they decided that as soon as the baby is born, they will take the fetal ABG of all the cases, all the children who were born there, to prove that ABG was normal. There was no depression at the time of delivery. Anyhow, okay, let us come to the third case now, a gynae case. A 42-year-old female comes to the OPD with a huge ovarian mass, as थोड़ी सी acidity रहती है, and bloating, and I'm not able to digest the food well. The cycles are regular, no problems at all. And then so you order an ultrasound. Now ultrasound to कराई, ठीक है जी ultrasound करा के. You order an ultrasound and then finally she comes back with a 10 by 8 centimeters ovarian mass in the right side. The left side is absolutely normal. There are speculations, there are calcifications, there are irregular margins and multiloculated mass. So you order, taking it 42 years of age, fingers crossed, you order a CA 125. And it comes out to be more than 500. So everything goes in favor of, 90% chances of that you are dealing with an ovarian malignancy. So you order a CT scan, an MRI, whatever you want to find out the notes for, how to follow up the patient further. Saying that it is only one-sided mass, you take up the patient for laparotomy. The treatment for an ovarian cancer is suspected ovarian cancer, of course, because the reports will come only after you do a staging laparotomy. So treatment for suspected ovarian mass is you do a laparotomy, a staging laparotomy. You take a fluid from all the fossa, cut off the sample, send for histopathology, report IE, and then we will decide further what to do or not to do. So any problems in such a case? Okay, I'll tell you the further management what happened. We did a salpingo-oophorectomy, but देखने में on gross examination, देखो बच्चों, that is the importance of the patho batch. You know, there are two things in pathology: a gross examination and histopathological examination. Gross examination से हमारी आंखों से हमें देखना आना चाहिए कि what is problematic and what is not problematic. Okay. So on gross examination also you could feel that the mass doesn't seem to be good. It has multiple speculations. बार-बार निकले हुए हैं. सब जगह omentum चिपकी हुई है. That means it is deriving its blood supply from the omentum, and you take it for granted that this mass is not going to be a healthy mass. So anything you can do in between rather than closing up the patient. Anybody? Okay, there can be two approaches. जो initial approach थी और जो अब guidelines के हिसाब से जो new approach है. I'll tell you both of them. What was done initially was take out the mass because the patient has given you the consent of only the removal of the mass, the ovarian mass, 10 by 8 centimeters के mass की removal की ही permission है. Remove the mass, send it for histopathology, close the abdomen, shift the patient outside, all done. आधे घंटे का काम है, patient is fine. But after 7 days, the histopathological report comes out to be epithelial cancer of the ovary. Now what? The treatment of epithelial ovarian cancer is? Anyone? Stage 1 की भी epithelial ovarian cancer treatment is? जोर से बोलो बच्चों. बोलो, it is okay. Nobody else knows. It's okay. Salpingo-oophorectomy. Anybody else? Epithelial ovarian cancer. The complete treatment of epithelial ovarian cancer in a 42-year-old female, even if it is grade 1, stage 1, it is TAHBSO. Hysterectomy with bilateral salpingo-oophorectomy. But what we did? We did not do what the doctor did. Only the mass was removed and rest everything has been left behind. So she is bound for a recurrence. Or else you take up the patient for a second laparotomy again and remove the uterus, the other side tube and the other side ovary. So any problems which you can face in such a patient? Anyone? जो किया ठीक किया या जो किया वो ठीक नहीं किया है ना? We are just supposed to discuss that legally. Final years. So the best part is there are two things. First is that on the onset you should have told the patient that if it comes out to be a CA or on cross examination, if it looks to be a CA, you should ideally go for a complete hysterectomy procedure. It should have been documented on the OPD slip itself or the file itself before taking up the patient for the OD. इतना समझाना जरूरी था. Still, if the patient doesn't give you consent, no ma'am, please kindly remove only the mass. Then you go for the removal of the mass alone. The second approach is, there is something known as a frozen section. Have you heard of a frozen section? ये तो pathology batch में भी सुना होगा, pre-final में भी सुना होगा. Have you heard of frozen section? Yes. So on table, a quick report within 15 minutes can be received from the pathology department saying whether it is a cancer or not a cancer. So
where this pregnancy has
yes. So now frozen section should be done in all cases where malignancy is suspected. और suspected means gross examination देखने से तुम्हें लग रहा है कि ये मास अच्छा नहीं है, ये कैंसर निकलेगा. Kindly take a biopsy from the other side. Don't leave the ovary as such. आपने एक बार बंद कर दिया, you really don't know whether the other ovary is normal or it also has cancerous cells. Remember that. So now that you have closed the patient, you will have to either take up the patient for a complete surgery again, second step, or you will have to take up the patient for chemo, then radiotherapy, and then if required, if recurrence occurs, again a mass is seen on ultrasound, you will have to take up the patient for second stage laparotomy again. And the patient's life is really in not exactly hell, but it is in fear daily. ये दूसरी ovary अंदर है, अब फिर से कुछ हो. One side I've had the other side will definitely grow again. That is the major problem you deal with onco patients. Then another thing is, we had a case when I was earlier. We had a case. It was huge ovarian mass, both sides. CA 125 more than 500. So हमें पता था ये COV है, and we know that we are dealing with COV. So patient was taken up for surgery, TH placed so done, staging laparotomy done. Under he capsulated mass था, so we were safe enough. We started her on chemo. But after 1 month, the husband came back from Dubai and he said, he came back. Later on, he came back and then he was like, Doctor, I'm really angry with you. अरे एक महीने बाद अब क्या हो गया यार? The patient is doing fine. Why is the husband angry with you? He said, Adam, I would like to act, because he had 2-3 more people coming with him. Later on, we realized they were all tonsils, जो उसके साथ आ रहे थे. And they were like, जब ovary में problem थी, why did you remove the uterus? It was really very difficult to make them understand. कि ovary में problem थी, तो why did you remove the uterus? Do you feel this question is okay? Anyone? You are directly labeling as a C ovary, C ovary, C ovary. You never said it is CA intervention. Then if the uterus, if the ovary had to be removed, why did you even touch the uterus? You could have left the uterus inside, no? We could have future prospects later on. Anyone would like to talk for this and against this? People think. Okay, bacha. Just because the lawyers were there with him, you are again supposed to open the books and you need to show it to them that the treatment for CA ovary, as I've already said, treatment for CA ovary is abdominal hysterectomy with bilateral salpingo-oophorectomy. Once the ovaries are removed, you have no purpose to keep the uterus inside. You can very well remove the uterus. In fact, the treatment guidelines also say clear BSO, दोनों ovaries remove करनी है, दोनों tubes remove करनी है, and uterus भी remove करना है. Yes. Yes, in fact, you should remove the lymph nodes as well. If it's a proven case of CA ovary, accordingly, you remove the para-aortic and the pelvic lymph node dissection. So just because कि लोगों को कम पता होता है, they can put you up in any question they want. You should be very well prepared with such questions. That can come only if your theory is very strong. You go by the guidelines. You don't do 1 inch here, 1 inch there. Don't do like that. You will always be safe. Go in the goodwill of the patient, but frankly speaking, be very empathetic to the patient. अपने आप को उसकी जगह पे रख के देखो. अपने आप आपको समझ में आएगा what would they want from you. And once you go like that, you will perhaps never face a problem. Any questions?
Thank you.
Thank you very much, especially for accepting our invitation at such a short notice. We have presented the very good 3 cases and with all the medical experts.
Practical problems is dealing with the radiologists also. If they miss some congenital anomaly in the earlier stages and the baby is born, now there are many cases against the radiologists also. Radiologists, they are also being.
Thank you, ma'am. Thank you.